Welcome to the Clinical Prehospital Care Research Forum Journal Club. Here in our PCRF Journal Club, we promote evidence-based practices by critically evaluating the latest science in emergency medical services. We hope our discussion will help advance EMS practice. Through the generous support of our sponsors, Limmer Education and ESO, we are able to make science more accessible and understandable.
Hello, everyone, and welcome to the September 2025 edition of the Prehospital Care Research Forum Journal Club podcast, sponsored by Limmer Education and ESO. The UCLA Prehospital Care Research Forum is dedicated to the promotion, education, and dissemination of prehospital research. We believe that it is the responsibility of emergency medical professionals worldwide to build a body of evidence to examine prehospital emergency care. Here, with the PCRF Journal Club, we take a closer look at some of the latest research happening in EMS. I'm Jeff Rollman, and I'm joined today by Dave Page and Dr. Tony Fernandez, Michael Caduce, and Dr. Bill Toon. And it is my great pleasure today to welcome one of the authors of this paper today, Dr. Esmeralda Melgoza, and a fellow Bruin. The name of the article we are reviewing is Factors Associated with EMS Clinician Preparedness to Provide Care for Patients with Limited English Proficiency, recently published in Prehospital Emergency Care. And we can go to the next slide. Just a quick reminder that this discussion is paired with an article written by our own columnist, Michael Caduce, in EMS World under Journal Watch. And we encourage all of our listeners to check out this article on emsworld.com under the category of education and training. And we'll also have posted within a few days, by the end of the week, to our RSS feed. So on Spotify and YouTube and a few other platforms, this will be recorded, the video or audio only, depending on the platform. But thank you all for joining us today. And as we begin, we want to remind our listeners that you can use the chat feature on your screen to type in questions and comments, and we will bring those into the conversation as we go. All right, well, let's get into it. It's so good to have you here, Dr. Melgoza, and definitely really want to spend some time talking about this amazing research that you recently published. But first, we'd love to hear a little bit more about you. If you could share a little bit about your background and then what got you into this wonky, wild world of EMS research.
Thank you, Jeff, and thank you, Michael, Tony, Dave, for the invitation to be here today. So I will be honest, when I started university back in, was it like 2011, I didn't want to be a researcher, and EMS was not something that was on my radar. I'm a Bruin, so I went to UCLA for undergraduate education. Then I also received my master's in public health and my PhD from UCLA. And when I was an undergraduate student, I was a history major. I wanted to be a teacher because that was one of the professions that I knew growing up. And something happened when I was an undergraduate student where my monolingual Spanish-speaking grandmother was involved in a hit and run. She was crossing an intersection, and she was struck by a vehicle that was making a left turn. And that experience really planted the seed for me to study EMS. I remember going on the internet and trying to figure out, who are these people that are out there in the community that are helping individuals like my grandmother who did not speak English. And you can see the parallel of that personal experience with this study that we're talking about today. But that experience really changed the trajectory of my life. And after that, I believe I was a junior or a a sophomore or junior in college when I decided to still complete the history degree, but then I minored in public health. And then from there, I went ahead and, as I mentioned before, pursued a master's in public health. And in the master's of public health, I had a requirement to complete an internship. So I completed that internship with the Los Angeles Emergency Medical Services Bureau. And I spent about a year there training and doing research with them. I really enjoyed it. So after a few years, I decided to go back and pursue a PhD and lead this work, where I felt that, there's a research gap and it's a very important topic. And so my training is in public health, but I focus on pre-hospital care. And also, as of recently, I've been doing more studies around the emergency department and 911 dispatch.
Thanks for sharing that. Yeah, that is a really interesting story. And I didn't know that about your grandmother, that I can't imagine going through that all and seeing that other side of it. But definitely a very personal story. And I know in many folks who are involved in the EMS world, it's often personal stories with family that kind of motivate us to get into this field. And that's really what helps drive us in what we do in clinical practice or research or wherever we end up going in our field. And I know you touched on it a little bit, but was wondering if you could tell us a little bit more about why you decided to study this. I mean, as a researcher, there's so many things in EMS that we're still trying to understand and still trying to figure out, but why this specific study?
So this study is the result of, at the time, I was a member of the Diversity, Equity, and Inclusion Subcommittee of NAEMSP. And we were thinking of different studies. This was back in 2024. We were thinking of different studies that we could work on as a subcommittee, and they were looking for people to lead studies. And I was very excited about this topic, and so I said, I can lead this study. And I want to say that this study would not have been possible without collaboration and partnership. Everyone on this team, and you can see their names here on the screen, has a different, not only personal, we all have different personal experiences, but also our training. As I mentioned, I have public health training. I'm very much an applied researcher. I believe that it's important for research to inform practice and policy. And so, we all worked together to make sure that, this publication would make it to the final line. It's published, right? And it takes a long time. I think probably from start to end, it was about a 2-year effort from idea generation all the way to publication.
That's actually pretty fast. I've heard of, or I know many studies that take many years. That I know we think in the EMS world when we're thinking seconds and minutes, 2 years sounds like forever, but that's pretty quick. But really great to see you on this paper, and really it's a rock star team through and through, starting off with you, Dr. Melgoza, and then all these other folks that have really different backgrounds, and was wondering how you got to meet all these people and really were able to make this happen and go from that committee to actually operationalizing that. I know we have many students that are listening now or might be listening to the recording, and they're thinking, hey, how can I get to know all these people and do research with a big team? So if you can share a little bit about that, we'd love to hear that.
Sure. So I found out about the subcommittee within NAEMSP through social media, actually. And I was in my PhD program, and I was looking for spaces that did research specifically on EMS. And I don't remember in which platform I saw that the subcommittee was, I think, sharing a recent publication. And I decided to join one of their meetings. And from there, I eventually, had the opportunity to lead this study. And some of the team members on this team introduced me to other people, specifically from NREMT or the National Registry. I'm going to be using these terms interchangeably throughout. And so that eventually evolved into this team that you see here.
That's great. I mean, just making those connections, and really these professional national groups really bring a lot of people together. And it's good to see that you're actually able to go beyond just talking, but to actually studying and researching and doing this amazing work. But wanted to dive into the paper now. And just a reminder to all of our listeners, it's posted in the chat, both a link as well as a PDF upload. So please feel free to follow along either now or on your own time. But going into this paper, just want to start off with the introduction and why this is something that we even need to talk about and study. But we know there's data out there. There's obviously limitations with data, but something like 30 million Americans have limited English proficiency, that LEP acronym that we use throughout. And that's about 10%, 8 to 10% of Americans. But that number really varies state by state. In California, about a quarter of Californians potentially have LEP. Texas, about 14%. Other states are also a bit higher. And we see that there is definitely pretty big differences and disparities. And there's this term that we use in public health a lot. I know that you and I use this term, social determinants of health, all the time. And it's something that we talk about a lot, but isn't necessarily talked about so much in the pre-hospital setting. I was wondering if you could tell our listeners a little bit more about what are social determinants of health, as opposed to the things we think about like clinical history, hypertension, diabetes, and then how does LEP factor in as a potential social determinant of health?
Absolutely, Jeff. And I do, before I get into the social determinants of health or social drivers of health, I want to really focus on the why, right? Why are, when I embark on a project or on a study, I always think about the why. Why is it important for me and my team to study this? Because there's so many different topics that one can study, as you were mentioning, right? And so you shared some statistics. So approximately 30 million people in the United States have limited English proficiency. We know that this country is diverse across different dimensions, whether it's language, whether it's race, ethnicity, religion, etc. And so with this paper, we really focused on the linguistic component, but I really want to frame this in the sense that we really need to think about this in an intersectional way as well, where we're thinking about the different dimensions where people are coming from. And as you mentioned, limited English proficiency does vary by state throughout the country. I'm in California, which is the state that has the highest prevalence of individuals with limited English proficiency, but there are other states that are also at the top, like Texas, Florida, New York, and even in states like Georgia, right? The percentage of individuals with limited English proficiency, although it might be low, there's parts that are increasing as well, right? This rate is increasing across different states. So going back to your question about social determinants of health, or in the paper I talk about social drivers of health, really thinking about the multi-level factors. And when I talk about multi-level factors that influence health, we can think about individual level factors, but not just individual level factors, like our attitudes, our beliefs, our knowledge, right? Those are individual level factors, but also thinking about interpersonal level factors. What are our relationships with other people? Who's in our social network? Are we isolated, or do we have these social connections? And then thinking about community or neighborhood level factors is also important. Where do people live? Where do people work? And then also structural level factors, right? What are the policies in place? Or sometimes there are no policies in place. And so really thinking about the multi-level factors, I think, is very important to frame. That's my intention in framing this study, but also a lot of other work that I'm involved in. I think it's very important not to blame the individual, but really think about the factors across these multiple levels that I mentioned.
Yeah, thanks for explaining those and the whole motivation and the why. I mean, it's so important that we do these studies, not just because, hey, there's a survey and we can ask some questions, but because we definitely want to impact policy, impact change, and hopefully reduce these disparities and really improve outcomes ultimately. So really important that we're doing this. And you discuss in your paper that there are real consequences of this limited English proficiency. Many of our EMS clinicians probably have been in situations where maybe they've had difficulties just interpreting what they're saying and trying to get a good history or information from the patient. But these can have serious outcomes with serious conditions like cardiac arrest. There can be delays in the dispatcher being able to provide CPR instructions. There can be delays in getting that ambulance and the EMS clinicians on the road on the way to the call, and there can also be delays in ambulance transport times. So there are definitely measurable outcomes that unfortunately are not ideal. So that's why we really need to be able to measure this to understand this. And then just looking at your study, I think you had a very clear objective, which is helpful to know what you're asking because there's a lot of directions where this could go. But your objective was to assess EMS clinicians' preparedness to provide emergency care to patients with LEP in the pre-hospital setting. And you also looked at EMS clinicians' experiences with professional interpreter services and their difficulty in accessing these services, frequency of use, and effectiveness. So very clear objectives and things that you're exploring and measuring. So not sure if there was any other framing that you wanted to add before we go into methods, but I agree that framing and the why is so important here. But we're going to bring in Dr. Fernandez here to talk a little bit about the methods. And great to have Dr. Fernandez, who's a former National Registry Fellow, so knows a ton about methods, but particularly about maybe what you were using. So great to have you.
Well, thank you, Jeff, and thank you, Dr. Mogoza, for joining us today. I think this is a really interesting and really important study, and I'm glad that you did it, and I'm excited to talk to you about it. So let's dive right in. So this was Jeff was nice enough to let us know about your objective, and there are only a handful of ways where you can actually get this information. You chose to do this with a cross-sectional study design, which I think was really important. Why do you think that this was the best study design for to address your objective?
Well, thank you so much for the question. And I do want to say that there are data sets out there, EMS data sets, but a lot of the questions that I have can potentially be addressed by some of these existing data sets, but I wanted to collect the data. And that was something that the team and I really talked about. What would be the best way to collect this data? And obviously, like any study, there are limitations, and we'll get to that. But what is, the best way that we could collect this data? And we had other factors that we considered. Obviously, cross-sectional survey designs, like you mentioned, Tony, this was a cross-sectional survey design, and this survey we collected data between October 10th and December 3rd, 2024. So it was multiple months that we collected data in partnership with an REMT. Also, keeping in mind that it's a partnership. So we need to make sure that all of the partners in this study are aligned as we're collecting the data and things like that. But yes, this was a cross-sectional survey, and it was a team decision to do it this way.
Yeah, I think there's a handful of ways, right, where maybe you can do some kind of focus groups, but if you want to understand how prepared folks are, you got to ask them. It's hard to know otherwise, and as we know, we've had a few qualitative studies on this podcast, and they are a lot very very time consuming. Not that this study didn't take a long time, but you were able to bring in a whole host of answers from a large sample of people in a relatively short period of time. I think that that's really important. So I am very familiar with the population that you sampled, but can you tell us a little bit about the population you sampled and why you thought that that was a population that was important to address this study objective?
Sure. And I also, before we get into the study population, if I can just mention a detail that I think was very important,
Absolutely.
that it was the first time that I had the opportunity to do something like this, which is cognitive debriefing. So one of the things that we did before we launched the survey is that one of my co-authors, I'm not sure if he's here, Jonathan Powell and I, we conducted interviews, cognitive debriefing interviews with EMS clinicians from the different NASEMSA regions to make sure that our survey terminology, our questions, and our answer choices were understood by EMS clinicians in different regions across the U.S. Because, like I mentioned, I'm in California, and I'm aware, that some of the terms that we might use here are different potentially from other states. So we found some interesting differences in terms that are used based on those interviews, and we were able to adapt the final survey based on some of the data that we found from those interviews. Now, going back to your question about, the sampling frame and the participants. So for the sampling frame, these were current registrants of the National Registry. And just to give some of you all who may or may not know, so NREMT is the largest national EMS certification agency in the US and maintains demographic data for over 500,000 EMS clinicians. Now, in terms of our participants, we included, our eligible participants were 911, non-military, and non-volunteer nationally certified EMS clinicians. And we excluded EMS clinicians who were younger than 18 or older than 85 years of age, were not residents of the US, were not currently employed in EMS, had not provided patient care in the past 30 years, and who had an emergency medical responder certification. So that was some of the inclusion-exclusion criteria. I know I said a lot. It's also part of the paper, so you can always feel free to take a look there. But that's what we use, and those were that was a sampling frame and the inclusion-exclusion criteria for participants.
Yeah, I think that's really important, and thank you for bringing up the cognitive debriefing. I think that's so important to make sure that you can understand how your survey questions are being interpreted by the respondents. And I bet you we can have you on another podcast just to talk about some of the differences around the country. I'd love to see that list. But yeah, thank you for bringing that up as well. And you didn't just do a cognitive debriefing, but you also did some pilot testing, right, on a small group of these clinicians who were similar to the population that you recruited for the larger study. Can you talk to us a little about the pilot study, the pilot testing as well?
So the pilot testing, it was more along the lines of making sure that we worked on this together. So it wasn't like an official pilot test. It was more of like, we made sure that members of our team who come from different disciplines, that the study questions, the answer choices also aligned before we did the cognitive debriefing. So that happened before, where we made sure that the survey draft
Very important.
is in good shape.
Yeah, and now we know that the National Registry, they have a large population of EMS professionals around the country, but they're not always the easiest to reach. And you did an electronic survey. How did you find some of these folks, and how did you recruit them to participate in your study?
So I have to say that this is where the power of collaboration and working together really is exemplified. So I was connected to Dr. Panchal from the National Registry through Remley, Dr. Remley Crow. So this was, the power of collaboration. They're both listed here as co-authors, but yeah, I think that's one of the things that I really want to highlight about the study is, working together is really important to make some of these studies happen.
Yep, absolutely. And we know Dr. Crowell here, and we miss her today, but we will see her soon. Um, and so recruitment can often be challenging, and certainly making sure that you have enough folks to answer your question. Can you tell us a little bit about how you made sure that the population that you're recruiting was diverse geographically and also representative of a larger sample?
Sure. So let me know if you hear any background noise. I think they're doing some construction for some reason. They just started. But
Can't
so
hear it on my end.
okay, perfect. So in terms of the recruitment, so we used a simple random sample of 19,000 nationally certified EMS clinicians. And so partnering with the National Registry, they've done surveys in the past. So we really worked with them, to see what has worked, what has been a little bit more challenging. And I will say that in terms of the response rate overall, we'll get to that, was low, but in terms of the number of people who responded, and we did some like statistical things on, and we'll talk about that in a little bit in terms of like how do we address some of these limitations, which all studies have limitations.
Absolutely.
But in terms of the sampling, did I answer your question with that? Would you want me to?
Absolutely. Yeah, I think that was great. And when we move into your objective or your outcome, so you asked folks specifically, how would you rate your level of preparedness in providing patient care for patients with limited English proficiency? And that was your outcome variable. And for your analysis, you dichotomized that into very prepared and prepared, unprepared or very unprepared. And you ran some models with these data to really tease out important factors. Can you tell us some of the factors that you adjusted for and some of the things you looked at in your models?
Sure, absolutely. And before I talk about the models, I also want to start by, before we run the models, we do some descriptive statistics, which we talk
Uh,
about in the study. So, means with standard deviations, frequency, etc. So you can read more about that. So once we have our descriptive statistics, we go ahead and for this study, we use LASSO to identify the key predictors of LEP preparedness. And then after applying LASSO, to minimize model complexity, we retain some key predictors. And so those key predictors, which you can see in the final model, the 6 variables that were in the final model included sex, race, ethnicity, average weekly calls, initial limited English proficiency, education, yes or no, and then additional limited English proficiency. So those were the variables that remained after using LASSO. And then I think you mentioned the multivariable logistic regression model. I think that's what's on in the results, the inferential results table.
Yeah, I think the analysis was very appropriate. And I do have to apologize every week for holding us up from your very important results. But your methods were really important and really well done. So I appreciate you and I appreciate this study. But before we do go to the results, I'd like to open it up to any of our other panelists or anyone listening live who would like to ask questions specifically about the methods. And thanks again.
Thank you. Something that I forgot to mention that I think is important as well is the use of survey weights. So that's also in the method section of the paper. So to account for potential bias due to non-response and ensure that the results were representative of our findings, we perform survey weights. We use survey weights, using the full national registry population. So I just wanted to make sure that that's mentioned as well.
Thank you. Yeah, I mean, I would say that definitely adds to this study, and we know that not easy to get folks to respond. And even though there's a lot of people who do respond, there's a lot who don't. So having survey weights definitely means that we can trust the results even more. Not sure if any of our other co-panelists have any questions or anything they wanted to bring up before we start diving into the results. We will go right ahead then. But your total respondents, you got 986 EMS clinicians that completed the survey in full. So the response rate was about 5%, which sounds fairly small, but we know with these large studies, that's not, I mean, 5% is pretty ordinary, I would say. And these study respondents, the demographics are fairly typical of what we would expect for EMS clinicians. So about 77% male, 86% white, 89% non-Hispanic, and almost 96% only spoke English. So showing that even though the country, we have a lot of Americans that are limited English proficiency, for EMS clinicians, not necessarily representative. And then we have our table 1 here that does a really good job of outlining some of these key demographics. Both the total column on the right, that total 986 respondents, and then split between those that are unprepared and prepared. So I'll definitely let our listeners take some time to look more carefully at this, but would love to hear your take about what you think some of the key takeaways and where you're most interested in finding some differences or lack of differences here.
So as you mentioned, Jeff, these findings, I wasn't too surprised in terms of, the proportions across some of these different variables. So for example, we know that EMS clinicians, and there's a lot of studies around this, a lot of data, they're disproportionately white males, right? And knowing that some of these communities, right, kind of thinking about the representativeness of the workforce for the communities that are being served. Language is just one dimension of this, but really thinking about, I know that there are current efforts to diversify the EMS workforce in an effort to also improve patient care, right? And so just to kind of add on to what you had already mentioned, I think that this table provides evidence towards that as well.
I think just one thing I would add in is this shows that you have a very sort of a similar sample size, right? It's nice to know sometimes that as we gain experience, we may gain more insights in caring for patients, and our procedural success goes up. It's probably assumed that some of our communication gets better as we get more experience, but we'll get into whether or not that played a factor in it. But you have a nice balanced sample size here, which I think is really important. And sometimes in previous studies, we've called that out and said just take into account the fact that our EMS workforce is not as diverse as it could be. And thus we can tend to see some, that can change our results or influence our results. So I just think it's worth noting in terms of some of the experience and some of the age, we have a really nice balance in a few of those categories where we don't always see it. We know that the EMS workforce, again, is not 100% representative, but in some of these categories, you did a nice job getting a representative balance. And I think that's important when it sets the foundation for our results.
Yeah, I think this is an excellent table, and you had a lot of things that you measured in your survey. So unfortunately, the full table, we don't have on the screen here. It is in that link with the full article. But just wanted to mention a few other things that even though there weren't significant differences necessarily, still interesting to point out that we saw that just over half overall of the respondents were employed primarily by fire agencies, by fire departments. This is almost all 911 EMS clinicians. We did see a pretty nice mix in terms of the actual physical location that, yes, primarily urban and suburban, but about 20% rural, which I know rural a lot depends on how exactly you define that, but was nice to see that we included sort of geographically, both through the SEMSO region, so looking at the country, dividing the country into 5 different regions, and then Census Bureau measures of population, a really broad distribution. And then finally, just looking at average weekly calls, we know that some EMS clinicians are just stacked up back to back and running, calls nonstop, whereas others might not be running as many 911 calls. And I think the fact that we see a lot of differences, not necessarily between unprepared and prepared, but that we see a lot in each of these groups shows that, yeah, these results and what we ultimately find probably pretty generalizable, even though there definitely are some limitations like all studies have. But want to go a little bit into what you actually found with the survey respondents. This wasn't exactly in the not just yet here, but looking at the survey respondents, just over half, so 58.3% reported that they delivered care to patients with limited English proficiency at least once over the past month. However, only 28.8% and 29.5%, so just over a quarter, indicated that they ever received any initial or additional continuing education on providing care with limited English proficiency patients. So even though most of these paramedics and EMTs and EMS clinicians are seeing limited English proficiency patients, they're not getting a ton of education on that. So I wasn't necessarily surprised by that, but I think it's really important that we are reporting that. And then looking at the access to professional interpreter services, 44.3% indicated that they had access to those, whereas 45.3% indicated that they did not have access. So about 50-50 split. And about 2/3 said that the professional interpreter service was easy to access, and about 90% said that it was effective and that it worked fairly well. So those were some things that weren't in the table, but really important results that were in the text. But I know you probably know a lot more about this and can provide some more context. So please jump right in.
Yeah, so I really want to highlight what you just mentioned, Jeff, which I think, we'll go into the findings from the models in just a second. I saw that that's the next table that you're going to show. But really, before we go there, I really want to talk about, what you just mentioned, right? So this idea, and I know that it's a lot of different numbers, so I want to go slow. So about 60% of EMS clinicians reported providing care, right, like you mentioned, to patients with limited English proficiency at least once over the past month, at least 60%. So 6 out of 10 EMS clinicians. And so really thinking about, we know based on the study and multiple other studies that they are interacting with members of the community who don't speak English or who speak very little English in these encounters in the community. So it's important for us to, one, recognize that is happening, and then two, to better understand, what are our EMS clinicians experiencing. And this is something that I think the survey really captured. We talk about, okay, if this is the linguistic barrier that is out there, how do we address this linguistic barrier? And, as you mentioned, in terms of the number, 44.3% of EMS clinicians who responded to the survey reported having access to professional interpreter services. Now, this was a little bit tricky because this raises questions. Is it that 44.3% did, like, the rest did not have professional interpreter services? Is it a training issue that professional interpreter services are there, but they're just not aware that they're there? Or is it that they're actually not there, right? So that's raises questions as well in terms of that finding. But one of the things that you mentioned that I really want to highlight as well is a lot, like 65% of EMS clinicians reported that it was easy or very easy to access professional interpreter services, that the services were very effective. But 65% of EMS clinicians reported using interpreter services less than 25% of the time or never. So although the services are effective and they're easy to access, why is it that they're not being used, right? And this raises questions. And there's some findings that we included here as well in terms of interpretation. Well, what are the different ways that interpretation can be accessed? So we asked about telephone, we asked about in-person interpretation and video. And based on the findings, approximately 77% of EMS clinicians reported that when they used interpretation, right, it was using a telephone, right? Something that we did not ask, that I'm currently working on several studies on at the moment, is around artificial intelligence. So how do we incorporate artificial intelligence? Is that being incorporated in some places? Yes. And if so, how do we move that forward? Obviously, knowing that there are also challenges and there's a lot of unknown as we go into these spaces. And so now going back to the professional interpreter services, why is it that they're not being used? And I think you're going to show a table down the line too of like, what are some of the most common challenges that EMS clinicians face when or encounter when they try to use these services? And the most common one that was mentioned was connectivity issues, right? I'm out in the field. I don't have good service. I can't access professional interpreter services. But there's others that I'm sure we'll go over in just a few minutes, but connectivity issues wasn't the top barrier that was mentioned.
Yeah, really interesting findings. And I know these sort of stark numbers that we just went over that you were really focusing in on are big and shocking and show that there's definitely a need. But I found that none of these numbers I find surprising at all, unfortunately, having worked in a few systems where almost all of them have these services available, but I know they're not necessarily used. But when they are used, I almost always hear positive things, that they are helpful and that they really can help improve care. But instead, just relying on things like family members or Google Translate or other non-professional services is being used. So I think we really need to understand why, so that we can really get past this and help make sure that these services that are available are actually used.
And I want to mention something, since you just discussed family and friends. So that was one of the findings as well from this study, is when professional interpreter services are not being used, the most common alternative is using family and friends. And in the discussion of the paper, we talk about, why there are some concerns around using family and friends as interpreters. And I can share my personal experience growing up. I had to interpret for my loved ones. I also speak Spanish, and I have loved ones who are, like I mentioned before, monolingual Spanish speakers. And so as a child or as a teenager, you may not know all of the medical terminology in Spanish that you need to do that translation. But not only that, in the paper, I talk about other concerns. So, for example, patients may not be honest with the EMS clinician out in the field because they might not want their family member or their loved one, their friend, to know, their medical whatever it might be, like their medical symptoms or maybe their medical condition, etc. So there's some patient confidentiality issues out in the field. We're also inhibiting honesty and open communication that might be present between the patient and the EMS clinician. And as I mentioned before, with my own personal experience, there might be omission in the data that is being translated because there might, the person translating might not know the medical terminology, or might be translating it in an accurate way. And one point that I think we don't talk about enough is that there's also cases where family members and friends may have an interest to misrepresent particularly in sensitive situations like elder abuse, child abuse, domestic violence, where the person who's interpreting may have other reasons of sharing inaccurate information. So these are some of the things that came up from this study that I think are important to also mention.
Yes, yeah, thanks for mentioning that. And I've been in those scenarios many times, unfortunately. I'm not fluent in Spanish, but I know a bit of Spanish, and there'll be family members on scene and they're translating for me. And I know that they're not saying certain things that I'm really trying to get across. And then they'll translate what the patient says. And I'm like, no, you're skipping some things. It's not exactly right. So that's when I know those professional interpreter services, I mean, myself included, need to make sure that we are using them more and feel more confident with them. I think perfect time to flip to our next slide, figure 1, with this forest plot. So if you don't mind just walking us through a little bit this forest plot and what we can take away from this, and if there was anything that you were surprised by that was found or not found, even not significant.
Sure. So just to orient people on the forest plot, on the vertical axis, you can see the variables that were in the model. So we had sex, we had race, we had ethnicity, average weekly calls, initial limited English proficiency education, yes, no, and additional limited English proficiency education, yes, no. So those are the variables. And then on the horizontal line, you see the odds ratio. And so the red line that you see there, it's the one. So if we had 2 statistically significant results, and those are the last 2 horizontal lines that you can see here. So at the very bottom, you can see, I don't know if Jeff, you're able to show with your mouse. If not, no problem. But basically, the initial LEP education, that line that you see there was statistically significant. And then the line below that was also statistically significant. So what we found here is that respondents with initial or additional education reported feeling more prepared when delivering care to patients with limited English proficiency compared to EMS clinicians who did not receive education on this topic. And both of the results, as I mentioned before, were statistically significant. In terms of what surprised me, well, this did not surprise me. These findings did not surprise me. I expected to find these findings, but I think it's important to document them in the literature, because one thing is having lived experiences or hypotheses, and another is actually finding study results that you're like, okay, I expected to find this, but after running all of these rigorous models and having different people on the team, work together, this is what we found. And so I think it's important to document it, and now it's here, it's in the study, and it's available for everyone to use for whatever action you all want to be part of.
Yeah, well, I mean, we definitely need this out there in the literature, so I'm glad that it's there. But as you've mentioned throughout, it's not just a matter of publishing this. You're doing this because you want to drive change, you want to drive improvements in practice and policy. So curious to hear your take on where we can go with this. And I think you did a really nice job explaining that in depth in your paper. And what's interesting is, unlike, I mean, I shouldn't say almost, every single month when we're doing these podcasts, we're finding areas of improvement. But often there's not necessarily laws or policies or regulations that are tied to them. Whereas here, there's actually several that might potentially mandate in a way that we need to think about this a bit differently. So we're not trying to, talk about legal particulars. We don't want our attendees thinking that we're lawyers or anything, but definitely important to know about what those laws are. So if you don't mind just talking about some of those laws and policies and where they could interact here.
Sure. So we talk about some of these in the discussion section of the paper. So the low reported access to professional interpreter services raises some questions around training gaps and federal compliance issues. Now, we know that laws can change, but the law at the time when I was writing the paper, there were, I think, 3 that I mentioned in the discussion section. So one is Title VI of the Civil Rights Act of 1964, which prohibits discrimination based on race and other identities, and has been interpreted also to require that federally funded programs ensure meaningful language access for individuals with limited English proficiency. Something else that I mentioned in the discussion was Section 1557 of the Affordable Care Act, which also requires covered entities to provide language assistance to individuals with limited English proficiency, and Executive Order 13166, which mandates language access for individuals with limited English proficiency in federal programs, including healthcare. So those are the three that I mentioned in the discussion. But like I mentioned before, laws and policies are dynamic. They constantly change, and it's important for us to make sure that we advocate for the policies that we believe in, whether or not they're currently in place or could be in place in the future.
Yeah, well, thank you for providing a bit more explanation on those. I could go on and on all day with different questions and thoughts about policy, but definitely want to give our other panelists a chance as we start to wrap up in the next 9 or 10 minutes with any other questions they might have for you, Dr. Melgoza. But in the meantime, I'm going to bring in a question that we got from our audience, from Katrina, who asks, do you believe high turnover among EMS clinicians, for example, EMTs, poses challenges to LEP education?
Katrina, thank you so much for your question. So you bring up an important point, right? That high turnover among EMS clinicians. That's also important. We don't talk about that, I don't think, at all in this paper, but I do think that it's important to consider. Now, with the EMS clinician turnover, that is a problem on its own. In terms of the education related to like initial education, the idea was that there would be some training that everyone who becomes an EMS clinician would receive. And so even though there might be like a high turnover, people leave, the people that are entering would receive this training or this education. And so I think you bring up an excellent point and to highlight the high turnover. Now, in terms of practically, my expectation is not that all EMS clinicians are going to know all the languages spoken in the communities that they serve, but rather that there are systems in place that they can easily access to troubleshoot these barriers that they encounter in the field.
Yeah. As we start to wrap up, I have, a few more questions, but definitely want to give everyone else an opportunity. In the meantime, I guess technology, was wondering your thoughts about technology and how technology can be used as a tool, but at the same time, knowing connectivity issues, if it needs to be used with a live connection and you're in a rural area or basement, there might be limitations. So I was wondering if you had any recommendations or thoughts on where technology could be a help or potentially a hindrance and harm.
Sure, and I'm happy to answer that, Jeff. And before I answer that, I want to encourage people in the audience to write their questions down in the discussion, in the chat, using the chat feature. Please ask your questions there so that we can have a discussion. That's the whole point of these talks, right? To really talk about this as a group. Now, to go back to your question about technology, the use of technology, in my opinion, is inevitable. We are seeing a lot of momentum towards incorporating technology in all aspects of our life. So I think that momentum is currently there, and it's only going to get stronger with just a lot of the forces that are currently kind of coinciding, I guess. Now, I don't think that for example, our legal system is keeping up with all of the different technological innovations and momentum and all of the things that are going on in technology. We just don't have the safeguards in place yet. And we probably will not have the safeguards in place because technology is just moving so quickly compared to a lot of other systems that it's very hard. In terms of incorporating technology, I do think it's important. I do think it's important to incorporate some level of technology into our work. I think it will help us focus on the things that require our attention versus maybe the minutia that we could be using our time for other things that are also important in our life. But I do, have that warning that, we need those safeguards too, as we're incorporating technology into our day-to-day lives, including in the EMS field. So that's just something that it's my personal opinion, but to answer your question.
Absolutely. Yeah. Guardrails are necessary. Technology is great, but we need to recognize its limitations. So thank you for that. And appreciate your reminder to our audience. Yeah, we definitely have a few minutes left, so please feel free to type in your questions. We'd love to answer them while we are here. And wanted to close by asking about what's next. And as we mentioned before, we know that almost every study brings up even more questions and more research is needed. But you've actually already started thinking about that with not one, but two future studies that you're already working on. So I don't want you to give away your findings or tell us too much, but if you could give us maybe a few hints about what is coming and what we could maybe look out for to get an even better understanding of what is going on in this area.
Sure, I'm happy to share. So as I mentioned to a few of you before the webinar started, and I'll share with everyone here, this study opened a lot of other doors to work in studying the studying language barriers in the 911 dispatch space. So I'm working on a national study around 911 dispatch and language access currently, and then I'm working on another study here in the state of California, and I received a grant for that last week to study that here in the state. And so I'm excited to continue doing this work and pushing the field forward. And as I said, applying the results, the findings in the real world. I don't want the publication just to stay in someone's email or, like a dusty bookshelf. Although I don't think we do that anymore, but either way, you get my point, right? I think it's important to actually apply what we're doing as researchers. And so, yeah, I'm very happy that you all gave me the opportunity to come speak today. And I'm excited to also learn more about your work. I know y'all are working on some very interesting things. I'm so happy to meet even after the webinar to continue those discussions.
Thank you. So great to have you, and congratulations on that grant. I know especially now it's not easy, so to get funding to do this critical work.
I was just going to say thank you so much for doing this work. Publishing is not an easy task, and to get it across the finish line, especially with this many folks that are really great authors, and getting everyone in all the cats to line up in the row, if you will, is never a challenge. I would encourage our readers. I can put the link for the supplement in the chat, but it really included some very interesting operational considerations. So if you're a leader of an organization that's out there, read the supplement, because it's really interesting to read about. Again, about half the respondents reported they did have access to some interpreting services. Again, I would like lots of questions for the ones who have no access to it. But if you do have access to it, to read the supplement, to find out what your agency can be doing better to make sure that you're using those tools, whether it's training or technology. Why would about half the respondents have it but not be using it on a regular basis? Oftentimes those are easy obstacles to overcome, but the supplement did a nice job of explaining a few of those things and showing the numbers. So for those folks that are out there, it's a great resource to use for your own agency. So and on the education side. So with that, I just thank you so much for taking the time to be on. I'll let Jeff wrap us up, but really appreciate your great work.
Thank you so much, Michael.
Thank you for that. And yeah, I just put that in the chat there. The supplement can be viewed by going to the article URL at the TNF online and has really great detail. But we're about to close out with that video. But again, just wanted to thank you so much for your time, Dr. Melgoza. I know you have a lot of studies, a lot of really important research that you're working on and getting grants to help fund some of this. So I know you're a very busy person, so we appreciate you coming on here, and we appreciate you publishing this and joining us and really inspiring all of us as EMS clinicians to do better. So just can't thank you enough. And As a reminder, we have our Education Research Journal Club podcast is next at the end of this month, Friday, September 26th. And we will be back here with our next clinical podcast on the second Monday of the month, which is October 13th. But thank you again to our guests, Dr. Melgoza. Thank you to our audience for joining us. Thank you to our fellow panelists, and definitely looking forward to another great discussion with you next time.
Thank you so much, Jeff, and thank you, everyone. Have a wonderful day.
Thank you.
We hope you have enjoyed and learned from this PCRF Journal Club. Please share it with other interested EMS professionals. An archive of past journal clubs can be found at pcrfpodcasts.org. You can also find us on Facebook at PCRF at UCLA and on our website, prehospitalcare.org. A special thank you to our sponsors, Limmer Education, providing educational tools for success at every stage of your EMS journey, and ESO, dedicated to improving community health and safety through the power of data.